Hello, thank you for coming to listen to me. I'm Estella Wetzel. I'm a Frontier graduate in class 78 and a Duke Johnson & Johnson Nurse Leadership Fellow for 2019 to 2020. I have had some experience working with the rural populations through Ohio. A few of the counties I've been in are Clark, Champaign, Ross, Fayette, Butler, Ashland, and Greene counties. I'm currently practicing in Beaver Creek. I have no disclosures, but this does not mean I'm boring. Some of my clinical experience was starting a primary care within a mental health center in Ross County. I learned a lot from that population and a lot from the culture of the area. The objectives of this presentation are to know how misinterpreted drug test results affect patients, understand the differences between screening and confirmation testing, identify potential drug cross-reactivity, recognize some ways urine tampering occurs, distinguish expected from unexpected drug test results, and discern plausible reasons for unexpected drug test results. Okay, consider this. MARSHA is a 68-year-old female who presents for her physical for her CDL. She just moved to the area and has custody of her adolescent granddaughter, but the girl's father is fighting to get her back since he was recently released from prison. MARSHA is diagnosed with chronic issues of major depressive disorder, hypertension, benign essential tremor, and gastroesophageal reflux. She was in an urgent care 2 days ago and is being treated for a UTI. Her current medication list includes misaline, sertraline, labetalol, ranitidine, and levofloxacin. You examine MARSHA and explain to her that it is clinic policy to obtain a urine drug screen on all new patients, especially when they're there for their CDL, to ensure safety and compliance. She gives consent and provides a urine sample. MARSHA's drug screen comes back the next morning, and the results show that she tests positive for methamphetamines, opiates, barbiturates, and benzodiazepines. So think about it. What do you do next? What are you going to tell MARSHA when you call her? And what can these results mean to her if interpreted as aberrant results? Okay, the problem is drugs are abused, prescriptions trafficked, traded, self-prescribed. We've all had patients who've decided that they're going to adjust their medicines from the way they feel rather than the way that we've asked them to take them. Prescribers are obligated to practice patient safety. We know how much a patient can take every day of a given medication. Patients haven't had that education, so they might not know, and they might not think it's going to hurt them when it might. Patients prescribed controlled medications must be monitored. We have a lot of new laws that indicate we have to monitor what's going on with them. Not all patients are honest, but not all patients are dishonest. Drug testing results are confusing. Interpreting urine drug test results is a skill that must be developed and honed. It's not something you're going to learn overnight. It's actually kind of like learning another language. And a drug screen is not a drug test. So what happens? You have false or incorrect negatives, which means the absence of the drug in the urine when you expect it, or false, incorrect positives when there's the presence of the drug that you don't expect. Basically, the outcomes for the patient are very similar. They can suddenly have the prescription discontinued. You might decide that you don't want to write for them anymore and wean them off, when actually they either need the medication or it has helped them get through life. There's always the verbal, implied, perceived accusations of trafficking or drug abuse. If they're new to your practice or they suddenly decide they don't want to be there, either you can dismiss them or they can walk away. They might lose trust in the healthcare system and figure, what's it worth anyway? Maybe they ought to be abusing drugs. They can have decreased or no access to care. If this is in their record, are other providers going to read it and then decide they don't want to take them on either? Okay, for the absence of the drug in the urine when you expect it, they might have a decreased quality of life. depression, uncontrolled pain because their medication is no longer helping them. They don't have it. Might have stress on personal relationships for false positives or false negatives. This can mean that the domestic partners are wondering what's going on. They doubt the veracity of the patient's claim. They could wonder what kind of person they're really with. This could be friends, partners, family. There could be debility. If you're in chronic pain, you're not going to be as able to do things as you were when the pain was more controlled. Same with the psychiatric meds. If you have anxiety that keeps you from leaving the house, you're not going to leave the house. You could have a loss of job, income potential, employment, loss of professional certifications such as MARSHA's CDL. That means that you won't be able to support yourself if you can't work. You can lose custody of children if there's a court case. And there's possible incarceration for either case if they feel you're drug trafficking or if you're abusing. Not everybody, but if there's a history. Okay, so some quick facts. Since 2012, studies have identified a lack of inclusion of the skill of interpreting drugs in all levels of healthcare provider programs. This is physicians, nurse practitioners, physician's assistants. This is lacking in all of them. Some studies asked providers in a pretest to identify how confident they felt about drug test interpretation. On the whole, providers who felt the most confident in their skills did poorly on the pretest. That test was basically, it included things that would be found on a drug screen, and they didn't know what to do with it. Incidentally, a couple of the other studies indicated a gender bias, with female providers understating their abilities, feeling less confident, but performing better in interpretation than their male counterparts. Of the studies that mentioned the lack of formal education, they all agreed that it should be a necessary part of any healthcare provider's formal training. Patients are suffering from this. They get accused and they don't know why. So what can we do? First, understand the test that's being ordered. Be prepared to discover viable reasons for the results other than abuse. There are actual reasons out there. We're going to talk about some of those. Know that when you have an abnormal screen, you need to get confirmation. Understand cross-reactivity, and be prepared to handle unexpected results compassionately. No knee-jerk reactions. So let's clarify the terminology of what we're talking about. Urine drug screening is the initial, sometimes point-of-care testing that assists providers for immediate care. It's kind of like the urine pregnancy test. It's a dipstick or cup. Patient voids in it, and it'll tell you several things. One is the temperature, and another thing is little lights where areas will light up in different colors to tell if it's reacting to a drug metabolite that it's finding in the urine. Confirmation testing is the follow-up testing when the drug screen says, hey, we need to look into this a little further. Cutoff levels are the allowable amount of a metabolite or drug in the urine. And cross-reactivity are medications with metabolites that are chemically similar enough to trigger a positive response in a urine drug screen. So some things to remember about this is that natural opiates have morphine and metabolites in the results. So don't be shocked if you see morphine in some of the other drugs. The exception is hydromorphone because it is a morphine metabolite. Synthetic opioids should not have measurable amounts of morphine or morphine metabolites in their results. The 5-panel drug screen is not an appropriate screen for all controlled prescriptions. This only tells the 5 specific drugs in that test. Certain synthetic opioids will require specific testing. Have you ever tried to test for gabapentin or tramadol? Benzodiazepines will need specific testing, and this is by different generations of benzos. Heroin is an opiate, and we cannot test for synthetic designer drugs. There are simply too many of them, and they change too frequently. So let's compare Screening versus confirmation testing. Screening is the first testing. It's initial, it's qualitative. An immunoassay, it tells you classes of medication. It does not detect anything that's lower than the cutoff levels of a drug. So if the urine is dilute, it won't show the metabolites. And it cannot recognize opiates. Confirmation testing is secondary, used for confirming positive or negative results. It uses gas chromatography, mass spectrometry, or high-performance liquid chromatography, and it can recognize opiates. Screening has little sensitivity, variable specificity, many false positives, and many false negatives. It's inexpensive. You can use it in on-site testing. Now, although you will see it used in pain management settings, it is intended for a drug-free population, not a pain management population. This is just a quick screen. So sometimes when you see it used that way, it's just to indicate that they need to see a little bit more into the urine. Okay, it's not to be used for grounds for dismissal, referrals to addiction medicine, unless confirmatory testing is used to affirm the tests of screening. It can be used to identify specific drugs, including opioids. It's highly sensitive and specific. It's more expensive, but worth it. The results are slower from the lab, but this is the test that will tell you everything you need to know. It may not be covered by insurance. However, if your patient is on chronic pain medication or chronic psychiatric medications, it should be covered for monitoring. This can be used as grounds for a change in the plan of care, such as weaning off of the medication or even dismissal, and it is legally defensible results. In other words, screening tests at point of care are used to determine if a class of drug has been ingested. Cross-reactivity occurs, resulting in false positives. False negatives may be due to levels below the cutoff point. It's not intended to be used in a pain management setting as the only means of testing. Confirmation testing is sensitive and specific using advanced technology. This method should be used to validate screening results. Only confirmatory testing is to be considered as valid legal evidence. Negative results. When a positive is expected, negative results can be alarming. These are some of the reasons why you would find a negative result, and that is possible diversion. The patient ran short of medication due to self-altered frequency or dose of administration. The patient is taking less medication than prescribed, such as in PRN dosing. For example, more than 3 days off indicates that the patient is taking less medication and will not have the results, the metabolites in the urine. Might be something to consider, though, if your patient has 3 days off of their medication without ill results, then maybe it's time to think about weaning them down to a less strong medication, maybe to an NSAID versus the NSAID versus the opioid. Perhaps the sample has been adulterated. We'll talk about how these can happen in just a few minutes. The incorrect test ordered for the prescription medication. Immunoassay is not appropriate for synthetic or semi-synthetic drugs. For example, buprenorphine, oxycodone, fentanyl, and methadone. Order confirmatory tests. Unexpected positives. Oops, that shouldn't be there. Before you get too excited, consider your differentials. What else could cause the positive result? Possible substance abuse is one, but you have to correlate with clinical findings. Testing error, false positives, cross-reactivity with over-the-counters, contaminated samples. Could be lab error, testing or clerical. It could be that they've made an error in not cleaning their equipment, or that would be the poor technique as well, or wrote down the wrong thing when they were testing it. This is the only time you would do a rescreen. Individual variability in a drug absorption. Consider your patient's hydration status and BMI. Are the meds absorbed in fat or are they absorbed in water? Mild dehydration can concentrate metabolites of cross-reactive drugs, causing a false positive. Okay, with unexpected positives, except for the lab error, never rescreen. Discuss this with a patient in person. This is not a topic to delegate to the MA. Be non-judgmental and try to determine the cause of the positive result. Does the story seem legit and legal? Does the explanation fit with your pain management contract? Write down what the patient says. Use quotes. Check to see if cross-reactivity exists in any of their medications. Remember, a vacation to Colorado does not negate the pain management contract. If they use marijuana at any time and that's in your contract that they will not do that, then they've just voided the contract if they've gone to Colorado and had fun in the little green store. Do not give specific suggestions, just general concepts like reviewing the med list. For example, the screening shows that you have X in your urine. There are many explanations for this. I'm sending your urine to be tested further to ensure your safety. Is there anything that I should know that you have been taking in addition to your prescriptions so I can add that information to the order that I send to the lab? Okay. If the patient suddenly decides that they are having a problem, that they may be addicted and are looking for help, this may be the opportunity for change. You can at that time refer to addiction medicine if appropriate. Even if you don't believe the patient will follow through, make that referral. It might take a few times for the patient. Okay. Minimize erroneous results. Review all medications with the patients. List all prescribed medications, over-the-counter supplements in your order. If the lab has the order, they can help you interpret. Ensure appropriate collection of the sample. This includes a witnessed void, the temperature is correct, and the specific gravity is correct. Understand how urine can be adulterated. With the meds, make sure that you're listing everything from you and other providers. Now, with witnessed voids, they're never pleasant. No one likes to have someone hanging over them in the bathroom. If you do enough urine drug screens or testing, consider having the lab provide a technician who will do this for you. Free employee. The downside is that means you cannot bill for the collection or the testing. The lab does that. That's how they pay for the employee. Urine adulteration is a science like no other. It can be as simple as a patient sweeping a finger in the residue that remains in their medicine bottle, or as complex as using other medications or substances to change the urine. We'll speak on this a little bit later. But for now, let's explore cross-reactivity. Cross-reactivity means that one of the metabolites of each of these drugs is close enough to the metabolites of an amphetamine or methamphetamine to cause the screen to alert. Just look at that list. Beta blockers, Wellbutrin, metformin, fluoxetine, ranitidine, tyramine, labetalol. These can all show up in drug screens as amphetamines. Barbiturates can be cross-reacted with NSAIDs, ibuprofen, naproxen, phenytoin, and primidone. Benzodiazepines might be flagged if the patient is taking oxyprozin or Zoloft. How many times do you prescribe Zoloft in a day? Okay, cocaine is the one that has no known drugs that cross-react with it. Cocaine is cocaine on a drug test. It's nothing but cocaine. THC can be triggered with sativa, NSAIDs, and proton pump inhibitors. Think about it. How many of the commonly prescribed medications have you seen? How many medications that you have in your own medicine cabinet that could cause a drug screen to pop with something that you haven't taken? LSD, you don't see that a whole lot anymore out there. But imagine that your sweet little old patient comes in with some really bad back pain and you want to give a couple of Vicodin to get them through. Drug screen shows LSD in the system. Don't panic, look at this list. These medications are very common and very often prescribed or purchased over the counter. Again, Wellbutrin's on there. Cardizem, Benadryl, oxalamine, that's usually found in Unisom, Prozac, Zoloft. Methadone is our long-acting medication. It can have cross-reactivity in Benadryl, Unisom, Seroquel, and several other antipsychotropics. PCP, NSAIDs can trigger it, as can Robitussin, doxalamine, Benadryl, and Ultram. This is the first time we've seen tramadol rear its ugly head. It is different than any other medication we have. Watch for the cross-reactivity with this drug. So oxycodone. Oxycodone is an outlier. It can only be cross-reactive with other opiates, opioids. So it will never be with over-the-counters unless there is something going on, such as when they had codeine in the Excedrin several years ago. But you should never see it with an over-the-counter. Unexpected opiates can be triggered by dextromethorphan, doxalamine, fluoroquinolones, tramadol, verapamil, rifampin. Okay, so what should you see in a drug test? The metabolites. Metabolites, as you know, are the chemicals that remain in the body after metabolism. There are many of these, and this is what causes the most confusion in interpreting urine drug test results. Each medication or class has its own individual metabolites. The metabolites from different medications can be very similar to each other, which causes the cross-reactivity. There are so many of them that I'm attempting to break it all down to make it easier to learn, to refer to the tool, and reinforce your knowledge about these. So let's start demystifying the metabolites. We're going to have a basic diagram. The drug prescribed will be at the top. The active metabolites will be in a solid purple. Inactive metabolites will be in a shaded block. The secondary metabolites are going to be lower and in a blue. So we're going to start off with the building block, morphine. Morphine is important because it's found in most natural opiates. The one exception is hydromorphone, which is a metabolite of morphine. You will have tiny amounts of hydromorphone on morphine drug tests, but you will never have morphine on hydromorphone tests. So we're going to go on to codeine. Codeine breaks into the metabolites of morphine, unchanged codeine, and norcodeine. Morphine will metabolize as it would as morphine itself. Codeine will break down into hydrocodone, about 10%. Now, if you have high doses of codeine, which are far higher than you would normally prescribe for a patient, you're going to see the hydromorphone show up in the urine from the morphine. Heroin, which is an opiate, has rapid metabolism that will change into the hallmark metabolite 6-MAM. This is usually within 8 hours of taking the heroin, administering the heroin. After that, heroin metabolizes identically to morphine. Get confirmation testing, clinically correlate the findings. This is most likely found in an emergency room situation, but you can't rule out finding it in the primary care setting. So if you have drug confirmation testing on a patient who shows the metabolites of 3-morphine glucuronide, norcodeine, and morphine included, it is reasonable to say the patient is taking codeine. So with heroin, we have one other problem. There's a conundrum. Heroin on the street, with all these names, has other drugs that are used to stretch it, such as fentanyl or acetylcodeine. This makes it very difficult to discriminate use of heroin, codeine, or morphine because there are simply too many metabolites. The problem is when all these other medications are added into it, there are more heroin deaths. So hydromorphone is an active metabolite of most opiates. Because prescriptive doses of hydromorphone are higher when it is a metabolite of the other opiates, the hydromorphone 3-glucuronide metabolite will be present in levels above the cutoff testing. Generally, you won't see it when it is a secondary metabolite. Hydrocodone will break into hydromorphone, dihydrocodeine, and norhydrocodone. Further, the hydromorphone will break into hydromorphone 3-glucuronide below cutoff levels. Additionally, because of contamination from manufacturing, it is common to have small amounts of codeine show up in the patient who is taking hydrocodone. This may change with time, but currently hydrocodone is not a drug that is tested at most federal workplaces. So you suspect a patient has overdosed and find the following metabolites in the urine: morphine, codeine, hydrocodone, and small measurable amounts of hydromorphone. What prescribed drug do you suspect was ingested? Codeine. If a patient shows hydromorphone and a dihydrocodeine in the urine without other metabolites, hydrocodone. Next, we're going to go to oxycodone, which breaks into oxymorphone, oxycodone, unchanged, and noroxycodone, which is the inactive metabolite. Now, it's an opioid. They're not natural opiates. They're not derived directly from the opium poppy. Think about the humanoid opioid. Sci-fi fans know that humanoids are not quite humans. Opioids are not quite opiates. Most opiates are detectable in the urine for up to 3 days. So the excuse of, I haven't taken it since last night, is not a valid excuse. Methadone has a long half-life. Breaks into methadone, unchanged, and a lovely metabolite called EDDP. EDDP is the hallmark for methadone. It's inactive, but it's not checked by most urine drug tests. So when you order the test, order it for EDDP with a cutoff of 300 for methadone and 500 for EDDP. If adulterization is suspected with the problem where patients spike the urine cup with residue from the pill bottle, or if you feel your patient is a rapid metabolizer of methadone, order the EDDP with GCMS testing. Now, the long half-life of methadone is the reason it is used to help wean patients off short-acting narcotics. It's also the reason that chronic pain management will order breakthrough pain medications, usually in a short-acting narcotic for patients. If you find methadone, or if the patient is prescribed methadone, always check the state monitoring system to ensure the metabolites that you're finding in the testing is expected, such as for breakthrough pain. Now, methadone has its false positives, including verapamil, diphenhydramine, and doxylamine. Order confirmation if the patient is on one of these medications and you find methadone. Fentanyl, I put this in here because fentanyl is used to stretch a lot of medications, including marijuana and heroin. If you suspect marijuana use or you find THC in the testing, please consider checking for fentanyl because it's contributing to a lot of deaths. Naloxone, Narcan. It metabolizes to noroxymorphone. Naloxone may be prescribed for patients with higher doses of opioids or opiates. Check metabolites to see if the patient has had to use this in the past 3 days. This could cause an acute increase in pain, and you don't want to start giving them more of their opiate because they have more pain when it's simply being blocked by Narcan. You want to know if they might have had an overdose scare and had to use their dose of Narcan. Ketamine was developed as a dissociative anesthetic and is often used in veterinary settings. It is abused and used as a date rape drug. It produces vivid hallucinations and loss of inhibitions. It's commonly ingested as an oral powder, liquid, or tablet, or it can be inhaled as a powder. Alcohol can increase the risk of respiratory depression and death. And sadly, usually it's slipped into someone's drug when they don't, or someone's drink when they don't know. Unfortunately, if some people use ketamine as a chronic med illicitly, it can lead to liver damage. Okay, tramadol. Tramadol metabolizes into O-desmethyltramadol and nortramadol. Together, those two will further metabolize to O-desmethyl-nortramadol. It's the O-desmethyltramadol and the O-desmethyl-nortramadol that are the active metabolites. Tramadol does not appear on most common drug screens. You have to order this separately if your patient is on the medication. Most benzodiazepines, which include diazepam, chlordiazepoxide, and temazepam, will metabolize to non-conjugated oxazepam or non-conjugated nordiazepam. Request testing for the metabolites. Let the lab know which benzodiazepine is prescribed. Other benzodiazepines, including lorazepam, alprazolam, and triazolam, are excreted as glucuronide conjugates. Order hydrolysis with beta-glucuronidase to be done prior to testing. This will ensure that you get the test that you need. Also, make sure you mention the name of the drug that's being prescribed. Clonazepam is an outlier. There are many false negatives common in this screening, so you want to look for the metabolite 7-aminoclonazepam. Request testing by medication name. This slide got messed up a little bit. I'm sorry. Benzodiazepine cutoffs vary depending on the higher dose. The older benzos have a higher dose, so they have the highest cutoff of 200 to 300. Newer benzodiazepines, you want to add the enzyme dialysis beta-glucuronidase, and they have a lower cutoff of 100. Clonazepam decreased the cutoff to 40 for 7-aminoclonazepam. Marijuana, hashish, and cannabis. It's the 9-delta-tetrahydrocannabinol, 9-THC. 9-THC will metabolize, and the metabolite is the secondary carboxy-delta-9 tetrahydrocannabin, THC-COOH, that you want to look for on the screens. Just a note, cannabis, like many drugs, can increase INR. So if you have a patient who has unexplained elevations in INR, talk to them and consider doing a drug screen. This may be something that makes you change from warfarin or Coumadin to an anticoagulant that does not require monitoring, if this is an option for that patient. Cocaine is complex. Cocaine is unique. There's no cross-reactivity. If you find cocaine metabolites in urine, it is cocaine. Look for gonine, and that would be right here. And you see that it's everywhere in the metabolites for cocaine. Amphetamine stimulants, selegiline, femproprazole, and benzetamine will all metabolize into methamphetamine and amphetamine. Clobenzarax alone will turn into just amphetamine. Ecstasy will come up as MDMA on testing, and that will metabolize to MDA. Okay, so urine tampering. We touched on this a little earlier. Dilution is probably the easiest way to tamper with urine. You make the specific gravity lower. You add water to the sample by overhydration or from finding a water source. It dilutes the urine metabolites and decreases detection of the illicit drugs or abuse of prescription drugs. Basically, it puts everything below cutoff levels so that you don't detect them. Prevention is to monitor samples. It's unpleasant, as we said before, but it does hinder tampering. Make sure you measure the temperature of the samples. If it's not warm enough to have just come out of the body, then it probably did not come out of the body. Reject samples with low specific gravity on dipstick. If it looks too light, just do a quick urine dipstick on it and make sure that it is actually concentrated enough that you're going to get a result. Chemical manipulation is another way. Adding chemicals to the samples. They react with the metabolites and make them undetectable or decrease below cutoff levels. It can cause false negative reactions, and you can detect these by appearance, smell, or suspicion. Taking other substances to mask the abuse. Niacin is very touted all over the internet to hide THC. High doses of niacin in an attempt to mask the THC have been documented as the reason for liver toxicity in patients. There's no scientific evidence that this is an effective masking method, but you find it everywhere. There's also diuretics people use to lower specific gravity. The one thing we have going for us on this is that the diuretics that are available over the counter have a tendency to turn urine blue. So if you have blue urine, you know it's probably been diluted artificially. Urine tampering, adding drug to the sample. This is the finger in the med bottle trick to transfer residue to the urine cup. Only the actual drug will show up on the test. If a patient wants to keep getting the medication but is obviously not taking it, consider the why of it all. Why do they want to keep taking it? What are they doing with it? Consider having patients wash their hands prior to the witnessed void, no contact with the urine cup until hands are washed. Please keep in mind that you will probably want to have the hand washing witnessed as well. So tampering with urine specimens, ammonia, you could obviously detect that with smell. Ammonia will block some of the metabolites, but think about it, only old urine smells like ammonia. So if you smell it, just say, oh, this is an old stinky sample, let's get a fresh one. Chlorine bleach. Okay. Chlorine bleach will bleach out the immunoassay screen and it won't show on the gas chromatography. Golden seal is an herbal supplement that causes dilution and decreases sensitivity to amphetamines and THC. Potassium nitrate can be purchased in a kit. It interferes with screening and testing for THC. Powdered human urine, you purchase that and you mix it with water and substitute it for your own urine. These are the little baggies that are kept in the flies of underwear to keep them warm, or at least mostly warm, until the drug testing. You will often see that they pull the baggie out and pretend they are voiding with it. Additives of hydrogen peroxide or peroxidase, can get those in the store or from a purchased kit. It interferes with screening for THC and opioids. Glucaraldehyde is in a purchased kit. It decreases sensitivity for multiple drug screens. Pyridinium chromate is in a purchased kit. It oxidizes urine and decreases sensitivity for multiple drugs in screening and testing. Vinegar decreases screening sensitivity for THC, and you could also smell that. Visine. Visine is an example. It cuts the urine below cutoff level. Put a couple drops of urine in the cup, and then they'll squirt the eye drops into the bottle so that it dilutes it, and you can't tell what metabolites are in the urine. Gives a false negative. Okay, water is an additive. Ingested, you can just drink enough to dilute your urine. Some people actually try to get the water out of the tap or toilet. That's why the taps are usually taped off so they can't be used, and there's food coloring in the toilet bowl and toilet tank. Some people also water things down with diuretics. All of those dilute the urine below cutoff level. This is an example of some of the kits that you can find on the internet. I did a quick search and I found these 331 kits in one search. So now, decreasing risk of tampering. Test randomly. Don't warn your patients or become predictable. I had a physician I was covering for who habitually called patients to tell them he would be getting drug screens on them about a week before their visit. It's kind of a way to say, hey, you have to prepare for your drug test, make sure you're compliant. Then he didn't know how to read the tests anyhow. Don't accept, I can't afford to have you do that. You can't afford to lose your license. Require witnessed voids on each visit. This is another way you could possibly foil people trying to tease you or get away with it. Randomly test the samples after they're collected. Make sure you have a chain of custody for each. Witnessing decreases the bagged urine from sources other than the patient's bladder. If it looks like water, do a dipstick. Wait for a second sample. Check the specific gravity. If it smells like chemicals, wait for a second sample. Never accept a home cot sample. You don't know where it came from. If the patient cannot void, consider alternative sampling, such as an oral swab, hair, blood, etc. Now, one of the most unusual results I've seen came back as not consistent with human urine. I was working in an occupational health clinic with space shared by pain management 1 day a week, so we had video surveillance for the parking lot. The manager reviewed the video the day the patient was in and the approximate time he was there. He was seen out in the parking lot with a large dog in the back of his truck that he seemed to be petting in a very unusual way. When questioned later on, he admitted to collecting the dog's urine with an adhesive catheter and transferring the urine to a sealed zip bag that he slipped into his fly in the front pouch of his underwear to keep it warm, and voided for the witnesses by picking off the corner of the bag while holding his penis and allowing the stream of urine to fill the cup, the dog urine, not his own. Before then, I never realized the extent to which people will go to beat a system, and that incident may be just what caused me to be interested in this project. So back to MARSHA, 68-year-old female. She's taking mycilline, sertraline, labetalol, ranitidine, and Levaquin. MARSHA's drug screen comes back the next morning and shows that she has methamphetamines, opiates, barbiturates, and benzodiazepines in her urine. What you're going to tell MARSHA is, hey, we got these back, and I need to prove that you're not taking them because I can see there's cross-reactivity in your urine. You are taking mycilline, which may reflect as the barbiturates. Sertraline may show up as the benzodiazepines. Labetalol and ranitidine may show as methamphetamines, and Levaquin can reflect as an opiate. All right, so we're coming to the end, and what I want to do is have you email me. I'm going to give you my address in a little bit, and I want you to know that this has been indexed to be used as a tool for you in the clinic. Each metabolite and drug is listed in the index so you can quickly access cross-reactivity and metabolization to help you continue to hone your skills in drug test interpretation. Please email me and I'll send you a copy of the presentation. And we're going to go through several slides, and you can see that everything is in there. My email address is right there. I'll be happy to answer any questions you have. Just please let me know what your needs are. Thank you for listening. Let's help our patients attain better outcomes, one drug test at a time. And my email is estellafnp@gmail.com. Thank you very much.